So, right, let me just pull this down so people can see this. Okay, so definition, knowledge mobilization. So the definition that we use is knowledge mobilization is about sharing knowledge between different communities to catalyze change. And those three things are really important. The sharing of different kinds of knowledge. So you have research knowledge, you have the knowledge of people who, for example, use services, you have the knowledge of those who provide services, you have the knowledge of policymakers. You need all those sorts of different knowledge combined together in order to make change happen. And you need people from lots of different communities to make that sort of change happen. And one of the things I've found in all the years that I've been doing knowledge mobilization is that when you're thinking about these things, the people who have to be involved are always many more people than you think they're going to be. And the main important thing about knowledge mobilization, or the main point of knowledge mobilization, is to make change happen. And there's lots of different ways to do that. So some of knowledge mobilization processes are around engagement and networking, educational events, co-production, and so forth. There's lots of different ways of making change happen. Now, this is our fab table. We are very proud, well, I personally am very proud of this table. And there's a lot of confusion around what is knowledge mobilization and what is communications. And so we came up with a table, and you can see at the bottom the link to accessing this table. And we're really happy for you to pick it up and to share it with as many different people as you want. Key concept about knowledge mobilization is around transformation. And the key concept in terms of communications is transmission. So knowledge mobilization really depends a lot about conversations and relationship building. And comms depends a lot about getting out things in creative, interesting ways to raise awareness. So thinking about knowledge mobilization, there's lots and lots of research into knowledge mobilization, but if you boil down, it comes down to sort of 4 key elements that you need to think about. So one is around the participants. So this is partly around the people who have to make the change happen. You know, who are the people on the ground who have to do things differently? But it's also broader than that. It's also about who are the beneficiaries of the change. And it's also often too about the researchers. The researchers often need to be very involved in helping to make the change happen, because they're helping those on the ground to apply the research within their particular context. So the next element is context, and context is crucial. And by context, this could mean resources, it can mean senior leadership, you know, whether or not they're interested or not interested in things. It can be how important in terms of the priorities of the organization that has to make the change. You know, so context is really key. And one of the things that's very interesting in knowledge mobilization is that you can take a proposed change and put it in one context, and it absolutely flies. And in another context, it goes nowhere. And it's the same change that you're proposing, but there's things about the context that mean it'll work or it won't work. And the other thing about context is it's a lot about luck. And so things can be going swimmingly. And I, for example, had a project that was all around implementing evidence-based quality indicators in community nursing. It was going really, really well. And then suddenly the national government came out with a whole bunch of their own indicators, and the project came to an end because it was too much for staff to do both things. So it was, you know, so context is really crucial, and it can change all the time, both positively and negatively. Then you've got your thing about your proposed change, another element is the proposed change. And Everett Rogers, way back when in the 1950s, I think it was, came up with sort of 5 key characteristics that mean that a proposed change is more likely to be adopted. And those are things like relative advantage, i.e., is what you're proposing better than what's actually in place right now? It's also things like trialability. Can you give it a go, pilot for a bit, and if it doesn't work, drop it? Observability, can you see the benefits quite clearly? So innovations, which research-based changes are innovations, if they have some of these characteristics, the more of these characteristics they have that are positive, the more likely it is for the change to happen. And then finally, you have change methods. So the change methods are going back to some of the slide earlier about knowledge mobilization. You know, are you going to make change happen through education? Are you going to make it happen through embedding new procedures into daily working? And usually what happens as well with successful knowledge mobilization projects is there are lots of different kinds of change methods, and they change over time, yeah, as the project develops. So it's not usually that you can just do one thing, like have a seminar and hey presto, things happen and people start adopting your proposed change. So the other thing about all of this is, what actually changes? So one of the things that's really interesting in knowledge mobilization is that it doesn't take very much. It's very soon when you start seeing changes happen. And where it starts happening almost immediately is around relationships. And that might be within the organization that people are working in that are making the change. So different departments start to having conversations with each other. It could be between different organizations. It could be between service providers and service users. There's all sorts of different kinds of relationships that change as a result of this work. And what's really interesting as well is oftentimes once those relationships are in place, some more really other interesting work comes out of the initial project. Another thing that changes is around skills. So many times in terms of knowledge mobilization and making change happen, you'll find that people need to be skilled in different ways. Whether it might, lately with COVID, we've all had to learn technology and upskill ourselves in that way. But there's all sorts of different skills that people have to learn in order to actually make the change happen. Oftentimes, too, new services have to come into effect. So I can remember one project I was involved in way back when was looking at using antibiotics for H. pylori to stop people from getting ulcers. And what they discovered quite quickly was that labs just were not up to speed in terms of being able to provide diagnostic testing. And so a whole raft of new services had to come in order to make that happen. And then finally, the thing that happens is systems change. And by systems, I mean everything from IT systems and how the IT might work, but also in terms of the way things are done, the processes that people use in order to manage their daily working lives. So we've come up with sort of 3 key questions in terms of knowledge mobilization and communications that really need to be thought about very early on. So one is, what do you want to be different because of your research? The second is, who are the people who can make this happen and how can you engage them? And how can you and they make it happen? So we're going to move now into the case study. And if it's possible, it'd be interesting for you to keep in the back of your mind these 3 questions, but also some of the things on the previous 2 slides. So, what's changing in terms of relationships, skills, services, and systems? Yeah. How is context affecting things? And what's really interesting about this case study is it seems on the face of it to be something quite simple and straightforward. And when you hear the story, you realize how not simple and straightforward these things can actually be. So we're going to bring up Joe and Deb and Zoe. So these are the 3 first guest speakers. So we're going to start with Joe. So this is the story of the Low Dead Space Syringe project. So Joe, you were involved as a researcher from the beginning. Do you want to tell us a little bit about who you are and the research underpinning it and your role in the project?
Thanks, Leslie. So I'll just paste a link to the ArcWest website if anyone wants to read more about the project, because due to time, we're not going to go into a lot of detail. I'm a research fellow in the Bristol Medical School, and I work within 2 NIHR funded organisations, ARC West and the Health Protection Research Unit. So the research project that we started with was about the acceptability of detachable low dead space syringes, which limit the dead space between the hub of the between the hub and the needle, which can harbour things like bacteria and viruses. So changing this type of syringe and supplying them through needle exchanges can help protect people who inject drugs from the risks of infection. So the aim of the research carried out by ARC West and the Health Protection Research Unit with Bristol Drugs Project, Bristol City Council and Public Health England was to really explore the views of people who inject drugs and those who work with them on the acceptability of this, at the time, new equipment. And so we interviewed people who inject drugs and people who work with them in Bristol and Bath. And in a nutshell, we found that detachable low dead space syringes were likely to be acceptable. And most people really valued the feature less wasted drug, because there's less of that space, so less drug is kept in the equipment. And most people we spoke to also valued the reduced risk of infection. In terms of introducing the equipment, there was a preference for a gradual introduction in which people are given an opportunity to try it alongside their usual equipment before the old equipment is gradually phased out. So we used our findings to develop some recommendations for the introduction of this equipment, which included things like training and education for staff, information for service users, and particularly making the most of peer networks. And we recommended that the equipment was introduced gradually and phased out. So at the time of the project, although the equipment was available and had been rolled out nationally in Wales, the uptake in other areas in the UK was at an early stage, with only a relatively small number of early adopters using them. So we wanted to do some more work to try and implement our research findings to really support the uptake of the equipment. As Leslie said, you'd think this would be quite a simple, straightforward kind of change. And the way we did that was by co-designing some harm reduction materials with people who inject drugs, with the support of Deb and Zoe and many other people, including Mike. Shall I stop there?
Okay, because one of the questions I've got is, so you mentioned the qualitative work that you did around acceptability, but there was also some work around effectiveness, and wasn't there? And cost effectiveness as well, wasn't there?
Yes, so colleagues, I believe Zoe's on the call actually, again in Bristol, looked at the cost effectiveness of the equipment and found, yes, that it would be cost saving to introduce the equipment. So that's again another motivator for introducing it for services.
So there's quite a big body of research behind it, wasn't it? So there was like lots of things, lots of questions had been answered through research in terms of making this happen.
Yeah.
Okay, great. So that's, and so one of the questions to you, Joe, is I know you've been a major player in terms of making this whole thing happen. What was it that attracted Joe Keston to actually getting involved in this? Because you could have just written a few lovely 4-star papers and not done anything else. So why was it that you really wanted to get involved and do something more?
I think it relates to what you were saying earlier, that you have to really do things to make change happen. And it didn't feel satisfactory to stop after we'd published a paper. It didn't feel like that was enough. And with the support of infrastructure like the ARC and the HPRU, we were able to continue beyond that usual life course of a project where you publish the paper and, you know, and you're very pleased with yourself. And so I think it was an opportunity to do more and to think creatively. Yeah, and I was excited by continuing our sort of collaboration with Bristol Drugs Project to see what else we could achieve.
Okay, great. All right, so Deb, can you, I don't know where you are now, but can you unmask yourself?
I am.
And there you go. Do you want to introduce? Oh, I don't. Okay. Do you want to introduce who you are and tell us a little bit about how you got involved and what happened next? So Joe has taken us up to, there's lots of different people involved in a steering committee and they want to come up with some materials. So enter Deb Hussey. Now, who is Deb Hussey and why did you get involved and what did happen next?
So I did actually enter slightly before this point. So my name's Deb, and at the time I was part of a team at Bristol Drugs Project, and one of the parts of my role was to work in our needle exchange, and I was the safer injecting lead. So I was part of the team that used the recommendations that came with Joe's research to implement the changeover of equipment, so that we introduced low dead space equipment where possible, like we completely swapped out. So I'd been familiar with the research. I'd recruited some participants for Joe, and you know, and got to kind of know her around the project. And then when the steering group was held, I was asked to take part to talk about our experience of introducing low dead space following Joe's recommendations. Yeah, so I was there at the very first steering group when the idea came about that that there was going to be a second stage to the project, looking at the implementation of the research, and that it would be a good idea to have a harm reduction worker on board. And I became that harm reduction worker. My job initially was to go and talk to other workers, so my peers around the country, about kind of local issues, their experiences, if they had tried to introduce low dead space equipment, what it'd been like, what barriers there were, if they hadn't, what their knowledge base was like. And then I collated all that equipment and brought it all back. And we looked at developing the set of messages that finally came out of the project.
Okay, great. All right, so going back to the implementation of the low dead space needles in Bristol Drugs Project, tell me a little bit about in terms of services, skills, systems. You know, how did that work? Were there problems? You know, how did you guys make it happen?
So we've had to change our equipment here for one reason or another quite a few times. So for example, our Phipps 1 ml syringes, the company that made those like quite a few years ago, stopped making them. So we had to change to a different type of equipment. And the changeover was really, really challenging. Our client group, for multiple reasons, really struggle to accept change. And probably about 2 years after we changed out that equipment, we were still getting people complaining about it. It was really hard. So when we discovered we were going to be changing our equipment yet again to low dead space equipment, obviously there was some reluctance among the staff, because we knew it was going to be such a challenging thing to have to deal with. But by taking part in the research, by hearing what our client group felt about the equipment, what they felt the benefits were, knowing things that we could highlight to our client group, knowing, you know, messages that maybe they didn't find so acceptable, we were able to tailor our interventions. And then following the recommendations that Joe came up with after the research, I would say it's the smoothest changeover of any equipment change that we've ever experienced. You know, that, like there always is, there's a few people that held out for quite a long time and kept saying, have you not got any of the old stuff? But it went as smoothly and much more smoothly than any of us, I think, would have anticipated. It really wasn't that difficult to change over at all, just by following those really simple recommendations.
Okay, great. Thank you so much. So the research really helped. That's what you're saying.
Absolutely.
Really helped. Okay, brilliant. We love hearing that as researchers. Okay, Zoe, who is Zoe, and at what point did you get involved? And tell us, pick up the story from where Deb left it. So Deb left it. You know, you got these materials. What's happening?
So I'm Zoe Trindawidis. I'm the communications manager at NIHR Arc West. So that's the Applied Research Collaboration. I don't know if we've explained the acronym yet. So I guess I was sort of the obvious person to kind of help with the kind of comms side of this project. I think I wasn't actually at the sort of stakeholder day where they got loads and loads of people in. And from my memory, I think the sort of output of that was, we need a load of infographics. You know, everyone thinks infographics are super sexy, and that's what everyone wanted. But then the work that Deb went going into all those needle and syringe programs up and down the country meant that we actually had a much better informed idea of the sort of materials that we needed to develop. So in the end, we developed a suite of materials, but I was kind of brought in to help with the sort of design side of things. So obviously I do a lot of commissioning of various comms materials, so I know how to write a design brief. So I kind of came on board to kind of help with that. We had a number of people we kind of invited to respond, but there was one person who was like the really obvious choice as our kind of design agency designer to work with, and that was Michael Linnell, or Linnell, I never quite know how to pronounce it, and he has got this massive background in this area. I think he's created the Safer Injecting Handbook, which Exchange Supplies, who make the low dead space equipment, he's the designer of that. So he understood the sort of sector, he understood the people who we were kind of trying to communicate with really, really well. And I think having that designer who understood the sort of the landscape really made a big difference. So he wasn't just a supplier, he was actually a partner in the project, and that made a huge difference. And he was really, really keen. I mean, we would have involved service users, but we probably wouldn't have done it to the extent we did without Michael going, right, day one, we're going to have a workshop with them, you know. So we ended up with a much more sort of integrated process with lots and lots of involvement with the service users because of his input. So that was really important. Other things I did, so what we ended up producing were a video, which you'll see if you click on the link to the project that I posted in chat, which was to be shown in the sort of receptions at needle and syringe programs. We did a leaflet, which was literally just to put in people's hands, which was very nice. We also did a series of posters to be put up in receptions as well. And we sort of also got those as kind of individual digital files so that we could sort of share them on social media and stuff. So it's a real sort of suite of stuff, and a kind of world of difference between the infographics that kind of came out of that initial sort of stakeholder meeting. You know, it's through doing that work that Deb did that we kind of really understood what materials we needed to produce. I also got involved with the actual sessions with the service users, and as a comms person, it's a real privilege to actually be able to work closely with the people that the communications are going to be designed for, to actually design with them rather than just kind of like going, oh, this is probably what they'd like. And being able to be that involved and for them to be that involved, you know, I've never had that before in my career. So it was really like a real privileged position to have that input from those people. And I think they, by the end, became kind of experts in low dead space and were like advocates for it. They were saying they're going around talking to people they knew, like, oh yeah, did you know about low dead space? And sort of telling them all the facts that they'd kind of learned through the process. So, you know, it was a real, everybody kind of took something away from it, everyone who was involved. One of the sessions I ran with them was Language with Zoe, which Deb may remember. We found that hilarious for some unknown reason. And that involved us kind of trying to work out, you know, what kind of language we should be using in the materials, rather than making, you know, one of the things that came across loud and clear was that they really hated that kind of chummy, jokey sort of tone that a lot of materials for people who inject drugs kind of seem to default to. And that was a bit of a revelation. So actually, you know, we used quite formal, but kind of language that they kind of approved and recognized. So it was just so important to have that user involvement so that we could make it as targeted and as appropriate for them as possible. And I just wanted to also say I got my first ever academic paper out of it. So it was a real knowledge exchange, because like I never thought I'd have an academic paper ever. And there I did.
Okay, brilliant. All right, thank you so much. So from the three of you, because you were involved in the first stage, what worked well and what didn't work so well? Go, Joe.
I think working really collaboratively. Hopefully that's come across from what we've said so far. So working with really closely with Deb, in particular Deb having dedicated time, I think, was really important, and being able to come and work in our research offices, so we could sort of bounce ideas around together and have informal kind of catch-ups. I don't think Deb will blow her own trumpet, so I'll do that for you. But Deb had so much credibility, and was able to build good relationships, as she was describing, with other people working in the field. They could speak the same language, they had the shared experiences. So had a researcher try to do the work that Deb did, I don't think it would have been anywhere near as successful. I think the other thing that was really important was being open to sort of getting it wrong and starting again. And we were in danger at times of trying to reinvent the harm reduction wheel and include far too many messages. So being guided by our partners to keep it focused and have clear messages was really key. And just trying to create a sort of reciprocal relationship with Deb. So, Deb became part of the ArcWest team. She attended training, language with Zoe, that kind of thing. And yeah, I think that was really key, was that we were working in partnership. Deb led on the academic paper that we wrote and presented at a conference as well. That would be my sort of things that worked well.
Okay. So then the other thing just to mention is that you were able to buy Deb's time out, weren't you? Because you were successful in getting an ESRC Impact Acceleration Award, weren't you? So that's why you were able to get her time in. Okay.
Leslie, sorry, just we need to move on with time. Sorry, you did ask me to say that to you.
It's okay. I was just gonna ask one more question, but it's okay.
You can.
All right. So my only last question is, and I think this goes more to Deb, is how do you know that this made a difference? How do you know this made an impact, the work that you did?
I mean, on the small scale, certainly at Bristol Drugs Project, we have the materials on display, and our service users become blind to posters that are on the walls. They see them every time they come in, they don't notice them anymore. This is what, three years later, people still stop, they still look at them, and they still take the information from them to this day, as I think because of the way that they were developed, because of the partnership work, and because of the service user involvement, they're still having the same impact today as they did the first day that we put them on the wall. So low dead space is still a conversation that we're having in our service, most definitely.
Yeah, okay. And I'm just going to remind you about how you actually saw the posters on somebody's wall internationally, didn't you? Yeah,
it was on a Reddit thread where people take photos of the drugs that they're using and post them up, and then chat to each other about it. And somebody asked someone what the posters were in the background, and it was the low dead space posters, and somebody else commented, oh, that really reminds me, I need to get some naloxone, because the naloxone poster was up there. So they're doing their job all over the world.
Excellent. Okay, thanks so much. Okay, so thank you very much, Joe and Zoe and Deb. Right, so let's bring up, so if you three want to go dark, and if we can bring up Claire and Emily now. So Claire, pick up the story. So all the stuff that's been happening in Bristol. So how did you get involved, and what did you do next? Because now we're moving on to the national stage.
Okay. I'm just going to see if I can get myself on the screen. For the purposes. Oh, am I there?
You're beautiful. Yes.
Okay, fine. So I picked up the story a bit in my role in knowledge mobilization for the HPRU. We wanted to try and see if we could do to bring all the different pieces of research together, the qualitative research that Joe mentioned, the design research, but also the modeling research and the economic research that had also been done in the HPRU, bring it all together and communicate it more widely and to policymakers. So I drafted, with the help of Policy Bristol, who are brilliant, a policy report to bring all that information together and to kind of highlight some policy focused messaging. And with the help of Emily Crick from Policy Bristol, Joe and I were involved in a webinar that Policy Bristol has set up. And that was publicised widely to policymakers in the area of drug treatment and harm reduction, and we presented it, and Emily, the lovely Emily from Public Health England, who was then the lead for Public Health England for hepatitis C and for bloodborne viruses in people who inject drugs, was at that webinar. She asked a question, I think, in the chat, and I picked that up afterwards, and we had an email exchange, and we said we should meet, and that's how we started.
Yeah, and the beauty of this all too is this all happened during COVID times, which goes to show you that you still can do knowledge mobilization even when, you know, most everything is not in real life. Okay, Emily. So do you want to introduce who you are, who you were, who you are, and your involvement in the project, and what your vision was? You know, what did you want to be different because of all of
Yeah,
this?
thank you, Leslie. Thank you, Claire, as well, for that lovely introduction. So, hi, everybody. I'm Emily Phipps. I'm a consultant in public health. And up until about 2 months ago, I was the national lead for hepatitis C elimination and reducing infections among people that inject drugs. I've since moved on since then, and I'm a consultant in communicable disease control in Public Health England South East. And I'm pleased to say that some of my colleagues from the national team are online today. I can see Monica and I can see Erna, so thank you so much for joining us and still representing the national team, just to demonstrate that this is something that we're really passionate about, still locally and nationally. So yes, as Claire said, I joined this webinar and found it absolutely fascinating and really aligning with Public Health England, and I think it's safe to say as well NHS England's approaches to hepatitis C elimination. So as colleagues may well know, that England has committed to eliminating hepatitis C by 2025. And I think what has been the approach up until a couple of years ago was a very medical model of elimination, very treatment focused. And I think for that stage in the epidemic of hepatitis C, that was quite relevant and quite necessary, because there were these new treatments that were suddenly available to people that were a lot easier to take, oral compared to previous injectables. And so we really needed to get as many people as possible onto treatment. But then we start running out of people to treat. And what the focus needs to be from that point on is preventing people from catching it in the first place or getting reinfected, which is really unfortunate for our patients. And I know a lot of them find it incredibly disappointing and disheartening when that does happen. So finding all of the ways in which we can prevent infection. And this is something that was actually quite challenging for us, as people may be aware, with the Health and Social Care Act changes that came into play quite a few years ago now, that really took prevention and harm reduction out of the hands of the NHS and really limited what PHE could do in terms of having an influence on that sphere. So I was really excited to have the opportunity to speak to Claire, because this low dead space concept and the messaging around it, as Deb and Claire and colleagues have said, the misinformation that's still out there among both service users and staff felt really important and felt like something tangible that we could do something about. I think, sorry, that's my cat. I think the key way in which we wanted to do that is, I think in relation to the overarching theme of this session, is through mobilising that knowledge amongst key partners who may be unaware and may feel under-resourced to instigate change either nationally and locally. So with the help of Claire and also my colleague Georgia from NHS England, the three of us are co-chairing a national task and finish group with the overarching aims of increasing awareness and uptake of low dead space equipment through all providers. So I think the important thing there is through both pharmacy and through specialist needle exchange. And with the intention and the knowledge that this will be beneficial for a wide range of bloodborne viruses, but our focus and attention really has been from this hepatitis C elimination point of view. I think one of the main benefit for me personally has been the ability of having this newfound ways of articulating the debate and the discussion around low dead space syringes and equipment because of the work of the University of Bristol. It's really equipped us with that right language and the resources to have really productive conversations with both the manufacturers of low dead space equipment, the providers of that equipment, and importantly, we've also been able to facilitate experts by experience joining this task and finish group and being paid to do so, which is really important for us. So if there's anything that you wanted to ask me particularly, I'd be very happy to answer.
Okay, so just put into context, this task and finish group has met like twice so far now, hasn't it? It's just starting, isn't it? So you're still in really early days.
We are. So we've had 2 meetings so far, and I have to say that the first meeting was really enlightening in terms of showing us how little understanding we have of our baseline. That it's incredibly difficult to know nationally what is being provided to people and what is being taken up by people on the ground. I think that it's potentially well, it is a lot easier to gather this knowledge about specialist needle exchanges, drug and paraphernalia providers, because they collect a lot more data, but from pharmacies and other providers it's incredibly difficult. So one of the key things for us we're doing at the minute is making sure that all of our participants are committed to a standardized definition of what low dead space means, because even something as fundamental as that has been a surprising cause of debate. And then the next port of call for us is going to be creating some subgroups to look specifically at training for staff in the community, in pharmacies, for instance, as well as understanding if there are still any gaps, either geographically or in certain staff groups, training through drug services. And so I'm really excited about how this is going to go. We're also looking as well at seeing whether or not we can provide any kind of standard template service specifications, because from speaking to our colleagues from local authority who've been part of the task and finish group, we understand that they are really incredibly useful way of influencing change at the commissioning level. And so we're using the expert input from people in the group to also put those together, hopefully.
Brilliant. So that makes it part of the system is what you're talking about. That's great.
Yeah.
Okay, so we're running out of time. So I'm going to ask Claire, Zoe, Deb, and Joe, and Emily in the chat, each of you write one piece of advice you would give to people who are embarking on some sort of a knowledge mobilization project. Meanwhile, while they're doing all that, I'm just going to thank everybody for coming along. I'm going to share my screen again, and I'm going to try to share my screen again. Okay. Oh, why is it not moving on? There we go. So here are the details for myself and for Claire, if any of you want to follow up with us in any way whatsoever. Like I say, we are looking at running another series of webinars next year. So if you have anything that you want to, you think would be really good for us to look at, we'd love to hear from you. I want to thank Emily and Zoe and Deb and Claire and Joe. Thank you so much, first of all, for the fantastic work that you're doing, because it really is pioneering stuff to make research make such a big difference to so many people. So thank you for your work. And then thank you also for coming along to this webinar.